Hello, everyone. Good evening, all. Hope you all are doing well. Today, we are going to take a free trial role play session for new batch students. Um, we are going to discuss random role play, random cases, and doing random role play. So who wants to participate, you can write your name on the chat box and we can start. Um, Hi, Dr. Warut. Are you there?
Hi. Yes, I'm here.
Hi. This is your case and your 2-minute starts now. You can start.
Okay. Good evening. My name is Dr. Varot. I am a doctor in this clinic. What is your name?
Hi, Dr. Ramjan.
Yeah. Nice to meet you, Tayan. I want to congratulations again about this pregnancy. How was the previous antenatal care?
It's okay, doctor. I'm already 36 weeks pregnant, you know that, but last couple of weeks, I'm feeling like really, I'm feeling tired. Didn't have energy to do anything.
It's occur for a few weeks. Can you give me more detail about your tiredness? Is sudden occur or is gradually worse?
Gradually, doctor.
Gradually. Do you also have any fever?
No,
Yeah. Can you take everything normally? Any nausea or vomiting?
no, no, no vomiting.
I see. Do you also have any chest discomfort or any shortness of breath?
No, doctor.
Mhm. Okay. And how about how about your work to work and your bowel opening? Is everything normal?
Was that
Or how about the work to work?
waterworks?
Yes.
It's okay, doctor.
And how about the bowel opening?
Regular.
Regular?
Uh,
Any blood
sometimes,
or any blood
sometimes,
or how was it color?
sometimes, doctor, I'm having issue with my bowel movement. Like sometimes constipation, sometimes normal.
Mhm. And how about its color?
Normal po color.
Normal color. Okay. Uh, excuse me, Jen, how about your pregnancy? Do you start to feel or can you feel your baby kicking?
Yes, doctor.
Mm, excuse me, do you have any bleeding from down below or not?
No,
Okay. Um, uh, at the beginning of your antenatal care, do you have any blood check?
uh, blood check. I did, doctor. It's normal.
Uh, Everything is normal, right? Okay. And did you take any folate or any iron supplement, iron tablet?
I took multivitamin and folic acid.
I see. And do you still take it at the moment?
No,
Mm. Any additional medication?
no,
Okay. Uh, excuse me, do you have any change in weather preference?
no,
Okay. And okay, may I have also, do you have any past medical history or any surgical history?
no, doctor.
Okay. Excuse me, Jen, this is your first pregnancy or not?
No, doctor. It's my third pregnancy.
Oh, how about the previous pregnancy? When did it occur?
My firstborn, that was 5 years ago, and second one 3 years ago.
3 years ago? Oh, okay. And any problem during the delivery?
No,
Can you also tell me the mode of the delivery? Is normal delivery or any
uh,
surgery?
normal delivery, doctor.
I see. Um, how about your mood at the moment?
My mood is okay, just feeling tired, doctor.
Just only feeling tired. Okay. And excuse me, do you take any alcohol or any smoking?
No,
Sorry to ask about this. Or do you also have use any drug recreation?
no,
I see. After this, I will take a little bit privacy questions. If you feel uncomfortable, please feel free to let me know. Do you still have any sexual activity active or not?
yeah,
Uh, any pain or any bleeding after the activities?
no,
When did you have the last activity?
mm, maybe 1 month ago.
1 month ago, I said. Um, and do you also use any contraception like a condom?
Yes, doctor.
Okay, sorry. Do you have also have any discharge from the below? No breathing, but any discharge?
No,
Okay. And um, do you also have any previous infection in your tummy?
no,
Thank you very much for your history, Chen. After this, please allow me to talk with my exam. Oh, okay. Please allow me to check for the physical examination a moment. Okay, Chen, thank you very much to wait for me. From the history and your physical examination, I expect excuse me, may I also see the physical examination again, please? Okay, Jen, from the history and from your physical examination, I think I still not detect any serious abnormality at the moment. I expect that your thyroidness may be correlated with your multiple pregnancy. You have your pregnancy in multiple time, and the duration is not far from each other. That also may have a chance that you have your feel tiredness due to the anemia. Do you ever heard about this?
What's that, doctor?
Okay. Anemia is mean that the red blood cell in your body is low. During your
Your time's up,
pregnancy, you
doctor.
will
Uh,
8 minutes.
your time's up.
Yep.
Okay. Dr. Varud, nice performance. History, you took most of the question you asked me. That was really nice. You have good approach and good structure. That was fantastic. A few important point you missed. Like when you performed with me, I understand like your preparation, like I would say in the middle of the preparation. So that's why I can understand your approach, your structure was nice. The missing point in this case, like you all know that like any patient complaining about tiredness, you can follow tiredness cluster. In here, you can ask about like medical cause regarding tiredness, ONG related cause for tiredness, and any other previous surgical history, current pregnancy question. So the missing question in here, you didn't ask me any abdominal pain, which your patient currently having like dull abdominal pain, she's having intermittent, and also she's having like varicose vein and hemorrhoids history. So you asked me about like bowel history. I gave you positive findings about constipation. You didn't ask me further. Okay, that was the missing point. Coming to the third trimester question, you asked me about like baby kicking. That was really important. You asked me any bleeding discharge. That was fantastic. But I haven't noticed any. You asked me any leg swelling, headache, vision problem. So basically, patient is 36 weeks pregnant. That means you need to rule out any third trimester complication question. Okay. Physical examination, I'm not sure. Have you noticed patient having like varicose vein, which is more prone, like prominent on the leg, and also having pitting edema, external hemorrhoids, and also like other neurological findings, even though that clonus is normal, that tiredness, and if you are asking me pain question, I'll give you positive answer. So basically, it's a pelvic congestion syndrome. Have you heard about it before? So that's the case for pelvic congestion syndrome. Okay. So let's discuss the case so that you can understand which point you need to mention. So, a 37-year-old female, Mrs. Jane Doe, present to the antenatal clinic reporting a persistent feeling of tiredness over the past few weeks. She's 36 weeks pregnant. Task is take a history of presenting complaint, obstetric history, PV card, approach of management. So, your history, you can ask about how are you feeling today, Jane? Do you have any specific concern for today's consultation? I'm happy to help. So, this is her third pregnancy. Her previous two pregnancies were uncomplicated. Both deliveries were vaginal delivery. Medical history, no history of hypertension, diabetes, other chronic illness, surgical history, no previous surgery. Current pregnancy, she has regular antenatal checkups. No major complication until now. She's just complaining about persistent feeling of tiredness, increasing discomfort from varicose vein and hemorrhoids. She's also having pelvic pain. If you are asking more, patient might give you answer like that's dull in nature, worsening in the evening, and after prolonged standing. Okay. So medication, she just got some vitamins and supplements, social history, unremarkable other system like no headache, visual problem, no chest pain, short of breath. Occasionally, she got leg cramps at night. Okay, so physical examination finding patient appearance fine, vital is stable at this moment. Cardiovascular respiratory examination is okay. Abdomen examination, fundal height according to the gestational age, fetal heart rate normal, and there is no tenderness, no contraction. When you check the lower limb examination, you notice like there is a varicose vein noted bilaterally and more prominent on the left leg. And also there is a mild pitting edema. Rectal examination is showing external hemorrhoid, no sign of like thrombosis. Neurological examination is normal. So based on the history, physical examination finding, most likely diagnosis is a pelvic congestion syndrome. If your task is telling some differential, what could be your differential in this history of presenting complaint? You can give like anemia, thyroid dysfunction, chronic venous insufficiency. It could be normal physiological changes of pregnancy, including fatigue, varicose veins, and hemorrhoids. Okay. Um, now, always remember for pelvic congestion syndrome, patient might give you history of chronic pelvic pain, which getting worse with prolonged standing during or after intercourse or premenstrual period, and it's a definitely you should ask about that pelvic pain question. And multiparity is another factor, key obstetric factor for pelvic congestion syndrome, because that is more prominent in multiparous women due to increased venous load and changes for previous pregnancy. So the management plan is a supportive management. So investigation, you can go for like just a basic blood investigation, ABC, USC, thyroid function test. You can do Doppler ultrasound of the pelvic and lower extremity just to rule out like DVT. Okay, so symptomatic management, patient feels fatigue, you encourage like regular light exercise such as walking, adequate hydration, nutrition, recommend like frequent rest period, proper sleep hygiene. Varicose vein and pelvic congestion, what you can advise, like you can advise to use compression stocking to improve venous return, and also advise to elevate the leg when sitting or lying down, and suggest avoiding prolonged standing or sitting. Other things like if it's really bad affecting your patient daily life, if symptoms are very severe after consulting with the specialist, specialist might give some venotonic agent like Dasmin. For hemorrhoids, just advise increase dietary fiber intake, fluid intake to prevent constipation. Otherwise, like you can advise like cis bath for symptom relief, or like stool softener if needed. Okay. Uh, regular antenatal visits, monitoring and follow-up. You need to provide like normal varicose vein, hemorrhoids in pregnancy, like just the reading materials, and for the importance of symptomatic management, preparation for the delivery, like birth plan, postpartum care, you can advise your patient, and finish with 4R. Okay.
Thank you very much.
Okay, so let's move to the next case. Do you have any question for this case? If you have, you can write in the chat box, and we can move to the next case. Four hour means 1 hour for review. So if you are ordering some blood test, you are going to review like 1 week or 2 weeks later on, or when the blood reports will be available. Another hour for refer. If your patient needs referral to a specialist, you can make a referral. 1 hour for reading materials, and another are for red flags. So for any ONG case, obs and gynae case, like 4R, it would be all the third trimester complications. So if your patient experienced any severe headache, blurring of vision, bilateral leg swelling, abdominal pain, baby not kicking, any vaginal bleeding, discharge, you need to come to emergency immediately. You can ask a question after physical examination findings. Just make sure if you are making a diagnosis, um, you need to ask appropriate question. You need to ask risk factor along with some important differential to rule out other causes. And that's how you can make a correct diagnosis. So many candidates like mentioning, even though I made a correct diagnosis, but I failed the case. Because you failed, you didn't ask like other risk factor, why you are thinking this is the case, and why you are thinking other reason are less likely. You need to rule out, okay? But after seeing physical examination findings, if you miss some point, you can still ask few questions when you start explaining. So let's move to the next case. Who wants to perform? Yes, Dr. Hala, you see.
Hello, doctor.
Hello. This is your case, and your 2 minute starts now.
Okay.
You can start.
Okay. Hello, Sarah. My name is Dr. Hala, one of the doctor working here. I just noticed from the notes that you have a headache. I'm sorry to hear that. Do you have any pain at the moment?
No, doctor, not now.
Okay, that's good. So Sarah, so to help you, I probably need to ask a few questions if you don't mind. That would be okay with you?
Sure, doctor.
Okay, Sarah. So for how long you have this headache for?
For like almost 2 months, doctor.
Okay. And it is comes and goes, or it is a constant
Yeah,
headache?
comes and goes.
Comes and goes. Okay. And can you able to describe this headache for me? It's like a throbbing pain, aching, headache. Can you describe this headache?
Yeah, doctor, it feels like throbbing pain.
Throbbing pain. Okay. And is it on both sides or the whole head or just one side of your head?
Mostly my front part and I feel like back part as well.
Okay. So does this headache goes somewhere or the pain goes somewhere else, like to your neck, shoulder?
No,
Okay. And did you notice any other anything to make the headaches worse, like eating certain kind of food or lack of sleep or anything like that?
yes, doctor, if I'm doing any activities, if I'm bending over, I feel
Mhm.
like it's getting really worse.
And anything make it better?
If I'm taking rest.
Uh-huh. Okay. And do you have any other associated symptoms with headache? Like I noted that you have a problem with a vision. Do you have any zigzag? Do you notice any zigzag lines or any sort of photophobia or sensitivity to light?
No, doctor, it's just like dimming of the vision or some blurring of vision.
Okay. And any nausea or vomiting?
I feel nausea.
You feel nausea. Any fever? Any rash?
Hmm.
Does this headache affecting your daily activity?
Yeah, doctor, last 2 months, like it's happening like pretty much every day. And like
Mhm.
it's really bad.
Okay. Do you have any flu-like symptoms recently?
No,
No. Any earache or any problem with your ear?
I feel sometime like that whooshing sound in my ear.
hmm Okay. And this is associated with the headache. It's begin when the
Yeah,
headache started.
yeah.
Okay. What about your vision? Do you wear glasses or you have any regular checkup for your vision?
I do
Did
have
you not?
a problem
Mm,
with my vision.
Okay. Did you notice any sort of pain or tender on your face? Or you have difficulty opening your mouth?
No,
Do you notice any sort of neck pain or any problem with your neck?
no,
Any problem with your teeth?
no.
You've been under stress recently. How is your mood?
My mood is okay, doctor.
Okay. And do you have any medical issue, like any problem, hypertension, diabetes, anything like that? Any medical issues?
No, doctor.
Are you taking any certain medication?
Yes, doctor, I'm taking medication.
What sort of medication are you taking?
I'm taking some medication for my acne. I'm taking ibuprofen for headache.
Okay. Are you on using any pills?
No,
Like no. And do you have any? Do you drink drink or smoke?
occasionally, doctor.
Do you smoke occasionally or drink?
Drink occasionally, not smoking.
Okay. And do you use any sort of recreational medication drug?
No,
Okay. Does this headache wake you from sleep?
no, doctor.
Okay. And may I ask you a few questions, Sarah? Everything will be confidential. May I ask you about your period? Is your period regular?
Yeah,
Any problem, any concern about your period?
no,
Okay. Are you sexually active?
no, doctor.
Okay. And are you up to date for your pap smear?
Not done yet.
Not done yet. Okay. And you never been pregnant before?
No.
No. Okay. You said that you are taking some Provine. For how long you been using Provine for?
Was that?
The Provine, you said you're taking ibuprofen
Uh,
for
for my headache, doctor. And
yeah. For how long? For how long?
since I'm having this headache on and off.
And how many tablets are you taking?
Depends, doctor. Sometimes one, sometimes two.
And are you taking this tablet every day?
Not every day.
Okay. And what sort of other medication are you taking? You said for acne. Can I know
Yeah.
which? Do you know that?
Some type of antibiotic named
Mhm.
tetracycline.
Doxycycline,
Tetracycline.
tetracycline. Okay. Any other medication as well?
No, doctor.
Okay. Do you have any family history of migraine or any problem
I
with
didn't
family
know
history?
that, doctor.
Okay. Yeah. And what about as I mentioned, your headache? Do you notice any sort of watery eyes or like a pain in your eyes associated with the headache?
No,
Okay. And you said your mood is okay. You've been under stress. I know you are a university student, but you've been under stress um, last couple of months or being
no,
anxious?
no, doctor.
Okay. Um, okay, Jen. Okay, Sarah. Do you want to share with me anything specific that you're concerned? Do you have any concern about the headache, or do you have any
Like what, doctor?
like do you have any like a concern about this certain kind of headache? Like some people, they might have a fear of having such kind of headache, maybe associated with some nasty growth or anything that affecting your health. Do you have any specific concern?
No, doctor. I just want to know what's wrong with me. Is there any specific thing happen?
uh Okay. That's fine. I will try, as I mentioned, Sarah, to help you as much as I can. I will do the examination and I go back to you. Okay. Okay, Sarah. Okay, Sarah. Thank you for waiting. So from the history and the examination,
Your time's
I
up, doctor.
sorry, doctor.
Your time's up.
Up.
Yes.
Uh, oh.
What's your differential?
So I'm thinking about increased intracranial pressure because she's using medication, and I noticed the papilloedema on the fundoscopy.
Mhm,
I'm also thinking about rebound headache because she's been using Nurofen for probably a long period of time.
mhm,
Um, I'm also thinking about maybe tension headache being for cluster headache, which is unlikely.
mhm.
Um, um, uh, I also probably thinking about meningitis because there is papilloedema, but however there is no any like a sign of like a meningitis infection, and probably it's not for 2 months. Yeah, like also like a temporal arthritis, sinusitis, teeth problem, eye problem will be also my differential. But the main thing is, I think, the increased intracranial pressure and the rebound headache.
Okay, fantastic. Doctor, your performance was really nice. You asked me very like details history. Now look, in your main exam,
Mm,
definitely these things happen. If you are going to ask like many question, you might not complete your task. Okay,
mhm.
so
Okay.
definitely like your aim should be like complete the task. In here,
Mm,
um, patient age is 24 years. So you can ask like lots of question for headache. Temporal
mm,
arthritis, cluster type of headache is unlikely in this age group. You already asked me like
mhm,
any facial pain, other like symptoms, but you don't need to ask for each and every differential. If you're going to ask each and every differential question, you cannot finish your time. Okay, so just try to rule out life-threatening condition, infective condition, any trauma, definitely any brain tumor, like what could be the relevant in this age group. Okay.
Doctor, I thought that I have to wait for the card to appear. So that's why I thought I still have time. That's why so I don't know in the exam, do we need to
So,
wait for, because they said,
in the exam, they will tell you like history for 4 minutes, history for 3 minutes, and a PV card will appear. Okay, so
okay.
sometimes it will not. So you need to take a history, PV card will appear and give your diagnosis and differential. So again, you need to manage your time. Okay, so how much history you need to ask, and ask for PV card, give your diagnosis differential. Most of the time, they will give you like a prompt timer, like history for 4 minutes, 3 minutes, or 5 minutes. But you need to
But
practice in this way.
okay,
Okay.
but if they didn't give me time, do I have to wait for the card to appear and then I give the diagnosis, or
No,
what should I
you
do?
need to go with the flow. You should not wait for anything, because
Mm,
since your 8 minutes started, that means like your time is gone. Okay.
mm,
If like they give you prompt timer, that's fantastic. If not, just keep going. Okay.
okay. And do I have to, doctor, because she's a female, every time, even if it is not related, to ask about the 5P? I wasn't sure if I
No,
have to.
you shouldn't. The
Yeah,
issue is
okay.
it depends on your case,
Mhm,
and depends like do I need to ask like 5P for every female patient or not? To be honest, like if I'm telling you, you don't need to, but you might get like migraine case in your main exam. In that case,
mhm,
you need to ask. Okay, so it's
mhm,
totally depend. For example, in this case, I wouldn't ask like partner history. I'm not going to ask PAP or cervical smear question. What's give you extra information for that? Okay,
mhm,
so I will skip that one. Period question, I can just ask like, do you think that is related with your period? Like your headache is related with your period, and are you taking any pill or contraception method? That's it. And then
mhm,
I'm moving forward, because if you're asking details 5P question, you cannot finish with time.
mhm.
Okay. So
Thank you.
your differential was correct. Basically, it's a pseudotumor cerebri or idiopathic intracranial hypertension. Okay, so let's discuss the case. 24 years female, Miss Sarah Johnson, who is a university student, present to the neurology clinic with complaints of persistent headache and visual disturbance. Over the last 2 months, her vital sign is stable. Your task is take a detailed history of her complaint, PV card, give your diagnosis, and make a management plan. Very big case, so try to finish taking history within 4 minutes. Okay. So ask about headache question, ask about either it's a gradual onset or sudden onset. So it's a gradual onset over the past 2 months. Characteristics of the pain, throbbing pain, predominantly in the occipital and frontal region, and it lasts for a few hours, occurring daily almost, and it's quite severe, 7 out of 10 pain. There is also aggravating factor like bending over, any physical activity, relieving factor like any analgesia. Okay, associated symptom like nausea, blurring of vision, also tinnitus or sounds in the ear. Sometimes visual symptoms like double vision, seeing flashes of light, sometimes increased frequency of transient visual disturbance, and also patient having past medical history of acne issue, and for that reason patient is taking like medication. So you should ask specifically what medication you are taking for acne. Okay. Um, so last 6 months, patient is getting tetracycline for acne management. She's having moderate to severe acne. Other medication, no history of high blood pressure, diabetes, other chronic condition, no history of migraine before, just say occasional ibuprofen for headache and tetracycline for acne. Family history, no migraine history. Social history, unremarkable. Other system like no chest pain, short of breath, no significant weight changes, no history of trauma or recent infection. And here physical examination, vitally stable neurological examination, you could notice like there is mild bilateral papilloedema on fundoscopic examination, other cranial nerve normal. Also other cardiovascular, respiratory, abdomen examination, all are unremarkable. Okay. So based on the history, physical examination finding, your primary diagnosis, it could be pseudotumor cerebri or idiopathic intracranial hypertension, which is linked to tetracycline use. Other differential, it could be migraine, tension type of headache, sinusitis, any brain tumor or space occupying lesion, any venous sinus thrombosis. Okay. So the management plan, definitely you need to do urgent MRI or MRV of the brain to rule out any secondary causes of increased intracranial pressure. Lumbar puncture you can do, but first you need to do like make sure there is no contraindication for lumbar puncture. If you are suspecting like it could be meningitis, that time you can proceed with lumbar puncture. But at this moment, like patient having pain for last 2 months, no fever, no infective history, you can do lumbar puncture like at some point. Okay. Medication review, as I mentioned, like tetracycline, discontinue tetracycline, it could be the contributing factor, and consult with the dermatologist for alternative acne treatment. Other symptomatic management, headache and intracranial pressure. So always starting with the investigation first, immediate and long-term management. So investigation, we already mentioned about some basic blood investigation. You can go for lumbar puncture and urgent scan, definitely like a CT scan or MRI. And coming to the symptomatic management, medication review, headache, if you're suspecting it's a increased intracranial pressure, we can reduce the pressure by giving some medication like acetazolamide, pain management, lifestyle modification. But our first priority to make a correct diagnosis. Okay. And long-term management, you need to find out the risk factor for idiopathic intracranial hypertension and modify that risk factor. For example, if your patient overweight, you can advise like lose weight, taking healthy balanced diet, avoid any activities that can cause increased intracranial pressure like heavy lifting, straining, like that. Okay. Monitor and follow up. So you are going to follow this patient up with the investigation, but if you are suspecting any urgent review, in that case, you can send the patient to the hospital, and hospital, they can do urgent like MRI brain. Okay. Ophthalmology referral, because patient complaining about blurring of vision, dimming of light. So this patient also needs ophthalmology review to make sure there is no other like ocular pathology. Okay. Neurology follow-up, if it's a when you are making a diagnosis, it's a pseudotumor cerebri, that time patient need a long-term follow-up with the neurologist and provide 4R. Okay, so education, reassurance, and definitely like red flag. Uh, P PFE mean physical examination finding from examiner. Okay. What is 5Ps? 5Ps for any female or reproductive woman, you can ask 5P question. So 1P for period. You should ask details period question. Another P for partner, ask about either stable partner or any multiple partner history. Another P for pill, so any contraception use. P for pregnancy, you need to ask details about pregnancy question, any miscarriage. And last P for pap smear or cervical screening. Okay. So those things like what does it mean by 5 Ps, 4R? So those question, if you are coming with theoretical classes, you will get to know about details for that one, okay? Because it's a random role play session. We are discussing the case coming frequently in last few months, okay? As BMI not given. So if you're concerned like anything contributing her headache, so in that case, you can still ask about her body weight, okay? Look, you can mention any space occupying lesion or increased intracranial pressure. That could be the like that could related with medication intake. I think that should be okay. As I mentioned, first you need to rule out any contraindication for lumbar puncture. So lumbar puncture, not first stage investigation. You need to do like CT scan or MRI, and still like if you are concerned about anything, then you can go for lumbar puncture to check the opening pressure. Okay. Can you just list differential and not give a single diagnosis in case like that? You can, but the issue is you need to mention about management as well. So based on your most likely diagnosis, you need to give the management plan. For offline or face-to-face exam, you need to ask physical examination finding to your examiner, and examiner will give you findings. Okay, so let's move to the next case. Who wants to perform? Anyone who wants to perform? Yes, Dr. May, you can. Hello.
Hello, yes, are you audible? Am I audible?
Yes, doctor. This is your case and your 2 minute starts now. You can start.
Hi, this is Dr. May, one of the MO in this medical officer in this intensive care unit. Nice to see you, Michael. So, Michael, according to the notes, I noticed that you are the sons of the robot. Am I correct?
Yes, doctor. Can you give me an update about my father, doctor? I'm really concerned about my father.
Yes, yeah, I'm gonna tell you what's happened with Mr. Robert. So yeah, Robert is got the diagnosed with the septic shock. So have you ever heard about the septic shock before?
No, what's that?
Yeah, your septic shock is the condition that was the usually where there is infections. The infection is could be the somewhere else, but if the infection is not uncontrolled, it is going into the bloodstream and is spread to whole body. In that way, it can reduce the blood pressure. It can reduce the mental state. Mental state is altered, and also it can lead to the serious condition that we call the shock. So are you clear up to now?
Yes, doctor.
Yeah, don't worry about that. Right now, you are in the safe hand, and then we monitor the Mr. Robert in the intensive care with the we gonna we gonna monitor the 24-hour monitoring the vital sign, and then we already give the vasopressor, which means the medication to pumps the heart, and also we are giving the antibiotics. So usually as I mentioned, the medicine could the infection could be someone else, so we need to kill the bacteria inside his body. So are you along with me so far?
Yes, doctor.
Do you have any other question up to now?
So, how are we gonna manage?
How, yeah. So first of all, I'm sure that before we are giving the antibiotic, we are doing some investigation. So the investigation include the blood test. Usually the blood tests include the organ function test, which means the liver function, renal function, as well as we're gonna check the full blood count, which means we're gonna check the white blood cell inside the body, and also the infection marker like a ESR. And also I'm sure that they will also take the blood culture, so we will know which exact bacteria is spreading inside the body as well. And also that we are if we gonna okay, in the short management, we gonna also monitor the robot mental status. If the mental status is, since the mental status is an order, if the GCS skill, I'm sorry to using the medical term, if the mental status is reduced, and if Mr. Robert cannot maintain his airway, we need to give the incubation is like we need to put a pipe into the Mr. Robert airway. So, and then we have to connect with the machine. So, so machine can help with the Mr. Robert respirations and the breathing as well. So, are you along with me?
Yes, doctor, but you know that uh,
Mm-hmm.
my father has like advanced care directive, and my father has like full resuscitation plan.
Mm-hmm. Yes, you are correct. So, so for the full resuscitations, if the vital sign become deteriorate, which means the vital sign is become need to reduce, we have to, and then on the monitor, we are gonna check the heart rhythm. In the heart rhythm also, if the heart rhythm is become altered, and we have to go through the resuscitations. So yeah, according to the note, I also noticed that Mr. Robert give the advanced care directive, which is also the full resuscitation. So have you ever heard about the resuscitation before?
No, doctor.
All right. As I mentioned, we specialists, intensive care specialists, also will decide upon it, and also if we need the resuscitations, there is contain at least two part. We first of all we have to maintain the breathing system. As I mentioned, if the oxygen level is reduced, first of all we can give the oxygen. If the mental state if the Mr. Robert cannot maintain the airway, we can give the intubations. Don't worry about that. Mr. Robert don't know about that because we gonna give with the anesthesia, so he won't feel the pain. So another thing is that if the heart is suddenly stopped, we have to give the resuscitations, which is we have to do the chest compression. So for the chest compressions, usually we are gonna work with the teams. So in that way, we can get the Mr. Robert back to the vitals could be the back to be the normal. So are you along with me? Do you have any other question after now?
Anything else that I need to know, doctor?
Yeah. Well, yeah, usually so. And then we have to find. By the way, did you know that Mr. Robert have any other symptoms before this condition has happened?
Yes, doctor. Basically, the symptoms begin 3 days ago with the fever and worsening cough, and then he had that rapid decline with her, like with his confusion. Yeah.
Yeah, we have to find out the source of the infection as well. Yeah, and do you know that Mr. Robert has the hypertension and then diabetes? So is he taking regular medication and are you live with together with him?
No, he's living alone.
Okay, I got it. So we need to also exclude the some of the condition that was related to the hypertensions. Like if the hypertension's blood pressure is under control, if there is a high pressure, there is a leak into the brain. We call it the intracranial hemorrhage, and also, but this is unlikely because it doesn't associate with the fever. But we need to exclude that as well. So we need to do the CT scan head as well. And also for the type 2 diabetes, if it is not well controlled, it can lead to the serious condition as well. So we're gonna take the, okay, I'm gonna add one more investigation, which is the arterial blood
Your
gas analysis.
your time's up.
Okay.
Dr. May, very nice
Yes.
performance, nice explanation. The things I may like missing here, that is you didn't talk about like palliative care or like goals.
Mm.
Like, look, your patient already having advanced care directive mentioned that full resuscitation plan. But what happened? Patient already 87 years, having multiple comorbidities like dementia, high blood pressure, type 2 diabetes, and chronic medical condition. Now, you can mention like we are trying to stabilize the patient with those support. What happened? Any unlikely event if your father is not
Great.
responding well, that time we might think about like palliative care. So you need to talk about little
Mm.
bit palliative care or
Yes.
comfort care. Okay, because
Yes.
have you
Yes.
noticed your task is discuss about short-term, long-term management. So you mentioned about short-term management, what you are doing in ICU, that's okay. But long-term management, that could be the two things can happen. Either patient can recover fully, and that time you need to talk about like rehabilitation, like those things. And if not responding well, then you need to talk about like palliative care. Okay,
Palliative
so that's the
care.
purpose of this case. That's why
Yes.
son clearly asked you, doctor, my father has advanced care directive, but even though patient has advanced care directive for full resuscitation plan, but if patient not responding well, so that time you need to think about that. Okay.
Yes, doctor.
Let's discuss the case. Robert Miller, an 87 years male, was brought to the emergency department by his son Michael due to fever, altered GCS, and rapid breathing. He was diagnosed with septic shock and is currently on vasopressor and broad-spectrum antibiotic and admitted to the ICU with septic shock. So he has a past medical condition of chronic cough, dementia, hypertension, type 2 diabetes. Robert has an advanced care directive mentioned full resuscitation plan. So your task is talk to the son, discuss about short-term and long-term management. So history not your task, but the history, if you can ask son, like not a history pattern way, you can ask like, how much do you know about your father? Can you tell me what exactly happened at home? What was the symptom? Like just a 1 to 2 question to make a good rapport with the son, okay? So basically, symptoms began 3 days ago with fever, worsening cough, and also there is a rapid decline in GCS. The patient currently on IV fluid, vasopressor, and broad-spectrum antibiotic, and in ICU. Patient otherwise, you need to discuss with the son. So you can mention like, Michael, I understand this is a very difficult time for you and your family. Your father Robert is critically ill with septic shock. Do you know what is septic shock? So you can discuss like, which is a severe life-threatening condition that can caused by any widespread infection, and he is currently receiving medication to support his blood pressure and antibiotic to fight against the infection. Okay, and he's also on a ventilator to help him breathe. In here, so the short-term management plan, hemodynamic support, that means that his blood pressure, to maintain his blood pressure, we are giving some medication so that like it can perfuse to vital organ properly. We are frequently monitoring blood pressure, heart rate, urine output, other vital sign. Antibiotic therapy, definitely broad spectrum antibiotic coverage will be adjusted based on the culture result and sensitivity, okay, to fight against the infection. Respiratory support, mechanical ventilation to ensure adequate oxygen and carbon dioxide removal. Fluid management, intravenous fluid we are giving to support circulation and maintain hydration. And definitely regular blood test to monitor kidney function, body electrolyte and salt level check, infection marker. Also, we are doing some more blood tests based on the clinical response and laboratory findings, okay? So those are the short-term management plan in ICU, okay? Now the long-term management plan. If your father, like if Robert responds to treatment, we will gradually reduce the support he needs from medication and machine, okay? And he will require like rehabilitation to regain strength and functional, functional state. I understand that he has a medical condition of dementia, moderate. So, how much support he needs at home? Does he have any support at home, like any home care package? Um, um, how independent he is at home? Like you should ask. Any potential complication, like we are closely monitoring for any complication like organ failure can happen, secondary from infection or pressure ulcer, and cognitive or functional support. Okay, so basically we need to involve multidisciplinary team to support his cognition and physical rehabilitation. Now, palliative care and quality of life. It's important to understand that despite our best effort, there is a possibility that your father may not recover due to his advances and existing medical condition. Okay, his advance directive indicates that we should do everything possible, which we are committed to do, but we will continue to provide aggressive treatment as long as there is a hope for improvement. Okay, if your father not responding well, that time we need to think about like palliative care or quality of life. Okay, so we need to ensure Robert comfort and dignity throughout his treatment. At this moment, definitely we are giving all the supportive care in ICU, but just let you know, if he is not responding well, that time we can think about like palliative care as well. You should offer like emotional and supportive care for the family, regular update on Robert's condition and involving you in decision-making process. And the prognosis remain guarded at this given Robert age and comorbidities. And you will follow the plan as per intensive care. Monitoring will be crucial in the coming days to determine his response to treatment and chances of recovery. And you can finish with like 4 hour. You can mention like if you have any question, feel free to ask me. I'll give you regular updates on Robert's condition. You can ask like either you are next of kin or not, or do you have the authority to talk? To be honest, like it's not that much important, but if you want to ask, you can still ask. Can doctor recommend DNR as part of palliative care discussion? So goals of care, basically any advanced care directive or goals of care, you can discuss with the patient when patient is well or has full capacity to make a decision. If patient unwell, you can discuss with the family member. But if you are changing goals of care, for example, if this patient does not respond well with treatment, and if you're thinking like now it's time to terminate all the invasive procedure or active treatment, just ensure comfort care. That time, medical doctor or also has like medical enduring power of authority, like they can stop all the active treatment. Okay, but in that case, they need to discuss with family. If that's the question, I didn't get your question, doctor. Can we ask to arrange family meeting? Of course they can. So any patient in the ICU, you can give like regular update. Okay, so that could be one of the like mini family meeting, but if they need proper family meeting, you can still arrange family meeting. Okay, but any patient in the ICU, you have to give like regular update in the family. So that's the case. Let's move to the next case. Who wants to perform? It may be overwhelming for beginners or candidate who just recently passed MCQ. That could be a little overwhelming for you, but that random role play, we encourage for the candidate who is already like have a knowledge how to take history, who already has the knowledge about like structure, some of the cases. So you can come and do role play. And that's how like you can make mistake and you can overcome that mistake. Okay. For the beginner, you need to attend theory classes, because in theory class, you will get the idea about all the cluster-wise approach. For example, like medicine, surgery, obs and gynae, pediatrics, all the like system has their own approach and structure. You need to know initially how to take a history, physical examination finding, what important investigation you have to order, and what could be the important differential. So we are doing in a cluster-wise approach for the theory session. You will get the idea about details for those cases. And for that random role play session, people who already in the middle of their preparation or just book their exam, it will be good for them because they already know how to prepare. And actually main exam, you will get like random cases. Okay, it's not like you will get 4 medicine case, 4 surgical case, 3 or 4 physical examination case. It's not like that. It's just a random. Okay. um okay, Dr. Vinitha. Hello.
Hello. Hello, doctor.
Hi.
Hi.
This is your case and your 2-minute starts now.
Hello, Laura. I'm Dr. Vinita.
You can read for 2 minutes, and then when
Okay.
you mention like your 8 minutes started, you can start. So now it's reading time. Okay.
Okay.
You can start.
Hello, Laura. I'm Dr. Vinita. I'll be seeing you today. From the notes, I can see that you have a lump in your neck. Can you tell me some more about it?
Yes, doctor. Last 2 weeks, I noticed like lump on my neck. I'm just a bit worried about it, doctor.
Where is it located? Is it on the sides or at the middle?
In the middle.
Okay. You noticed it incidentally, or was there any pain associated?
No pain, doctor.
Is it increasing in size over the last 2 weeks?
No. It's just on the right side of my neck, doctor.
Okay. Are there any lumps in any other parts of the body?
No.
So there is no pain. Is there any difficulty in swallowing?
No, doctor.
Do you have fever?
No.
Do you have any tiredness or shortness of breath?
No, doctor.
Do you have any pedal edema, like edema in your legs or swelling of legs?
No.
What about your waterworks? Are you passing urine normally?
Yes, doctor.
Are you passing your poo normally?
Yeah.
Okay. And any change in weather preference?
No, doctor.
Do you feel any discomfort in your throat?
No.
Any pain in teeth?
No.
Okay. Do you have any other medical illness for which you are taking tablets?
No, doctor.
Other than this lump, do you have any other medical complaint?
No.
Okay. Do you smoke?
No, doctor.
Do you drink alcohol?
No.
Do you use any recreational drugs?
No.
Have you had any surgeries in the past?
No, doctor.
Do you have any allergies?
No.
Do you have any rashes in the body?
No.
Okay. Is there any family history of cancer?
No.
Have you been treated for any similar complaints in the past?
No, doctor.
Can I see the PFE card? Laura, how is your appetite like?
Normal?
Are you able to sleep normally?
Yeah.
No excessive tiredness or sleepiness, right?
Yeah.
Is it there?
No.
No. Okay. Okay. So, Laura, from your complaints and from my examination, I can see that there is a firm nodule in the right lobe of your thyroid gland. So, thyroid gland is a gland in your neck, at the center, which produces thyroid hormone. So, it is the thyroid hormone is important for the body, and in your case, the hormone production seems to be normal because you don't have any symptoms of overproduction or underproduction of the hormone. But there is a nodule, and we have to further evaluate that. We have to see why this nodule is present there. So we have to order some investigations. We need to do some blood tests. We have to get your thyroid function test done and complete blood test. We also have to do a US ultrasonogram of the neck to confirm the thyroid nodule. And you may need a nucleotide scan to look at the thyroid activity status. And we may also require a fine needle aspiration test. A needle will be inserted into the nodule, and the material will be taken on a slide and checked under the microscope to see whether it is any serious condition like cancer. Don't worry, most likely it is a benign nodule, and but still we need to rule out everything, so we may have to go ahead with these tests. So based upon the results of these tests, we will decide what further we can do. And I would like to refer you to a head and neck surgeon to look at your thyroid nodule as well.
Anything else that I need to know, doctor?
Sometimes the thyroid nodules can have overproduction of hormone or cause hypothyroidism. So in that case, you have to keep a note on your sleep. If there is any sleep disturbance, or if there is excessive sweating of the hands, or if there is bowel habits change, you have to report it. I will give you some reading materials, and I will give you a date to review with the investigations.
Okay. Anything else?
That's all.
That's all. Still you got time, Dr. Venata, 20 seconds. That's nice. You asked me history. That's history, most of the question you asked. Just checking, did you ask me about any loss of weight, loss of you asked me any loss of appetite, and you asked me any other lumps in the body, but did you ask me any about weight loss history?
No, weight loss I missed.
Okay, because you are concerned about any cancer, so just make sure you are asking like any cancer history.
Okay.
Otherwise, you asked me about fever history, other like swallowing things. That's really nice. Physical examination here actually unremarkable except thyroid nodule. And the management plan, you are going to do blood tests, including thyroid function, ultrasound, FNSC. That's like enough for this case. Okay, nice performance, Dr. Veneta. Just like when you perform, I feel like there is lack of empathy for your patient. So do you have a study partner?
I don't have a study partner right now.
Okay.
I'm looking for.
Perfect. So try to find a study partner, try to do role play, because this clinical exam is all about your how you are going to deal with your patient nicely. Approach definitely matters a lot. So I'm pretty sure you can overcome this. So just have a study partner and perform role play. Okay.
Okay.
Otherwise, like history, apart from that weight loss history, you didn't miss any key history. Most of the key point you already asked. Okay.
Thank you.
So let's discuss the case. A 25-year-old female, Miss Laura Martin, a marketing executive present to the primary care clinic with a complaint of a lump in her neck, noticed about 2 weeks ago. She is generally healthy, so task is take a detailed history of her complaint, PV card, give your diagnosis and counsel accordingly. Here ask about neck lump question. So basically patient has this lump 2 weeks ago, and that's the right side of the neck. It's 1.5 centimeter lump, firm nodule, but there is no pain, no voice changes, no swallowing issue, no breathing difficulties. Other systemic examination unremarkable. That means no weight loss history, no appetite, energy, is fine. No medical history, no thyroid issue, no radiation, no other significant medical condition. Okay. Family history, social history, and other system review, all are unremarkable. Then physical examination, when you checked that neck, patient vital is stable. Thyroid examination, there is a palpable firm nodule on the right lobe of the thyroid gland, and it's a non-tender. other examination are unremarkable. So primary diagnosis is a thyroid nodule. Your differential diagnosis, it could be benign thyroid nodule, thyroid cyst, thyroid adenoma, or thyroid carcinoma, or thyroiditis. Okay. So the investigation, what you are going to do, blood investigation, including thyroid function test. You are going to do a scan to check nodule size and characteristics of the nodule. If ultrasound indicates any suspicious lesion, you might go for FNSC. Okay, so the management at this moment, observe this nodule. If it is a benign appearing, asymptomatic, consider just a regular follow-up, doing repeat ultrasound and clinical examination every 6 to 12 months. But if anything concerning, you need to refer like surgical removal. So you need to refer to the surgeon, and also endocrinology referral. So monitor and follow up for further evaluation and management. If nodules show suspicious feature or any atypical cell in FNSC or malignancy, okay? Otherwise, like regular follow-up, and as I mentioned, like patient education, reassurance, and reading materials. It's an easy case, thyroid nodule. For online exam, you will get that physical examination finding card. You don't need to ask anything. Everything will be given on that card, okay? And based on that card findings and also history, you need to make a diagnosis and differential. So you can order FNSC if your task is order investigation, or what could be the appropriate investigation for this case. You can just mention you are going to do blood test, scan, like ultrasound, and FNSC. Okay, but if STEM mentioned FNSC already done, you might get the report that time. But if not done, you can order. Okay. Okay, let's move to the next case. Who wants to perform? Anyone wants to perform role play? If you have any question, you can write in the chat box. Any new candidate wants to perform? Hello. Is there anyone who wants to try? Sure, Dr. Mariam. Hello.
Hello, doctor. Yes, I'm here.
This is your case and your 2 minute starts now. You can start. Hello, Dr. Mariam. You can start.
Yeah, no. Hi, hi, Mr. Smith. My name is Dr. Mariam. I'll be looking after you today. How are you doing?
Hi, doctor. I'm okay. Just I'm having double vision.
I see. Okay. So since when did it start?
Last few weeks, I noticed that one, doctor.
Okay. Okay. And apart from the double vision, are you having any other symptoms?
No,
I see. Okay. And for the past how many years do you have the diabetes for now?
many years, doctor, more than 20 years.
More than 20 years. Okay. And how are you managing your diabetes? How are you controlling it?
Um, I'm taking medication and also I need to take insulin as well.
I see. Are you regular with your medicines?
Yeah.
Okay. Yeah. And how often are you, do you check your sugar levels at home as well with the glucometer?
I try to check it. Yes, doctor.
Okay. And do you have your regular checkups with your GP regarding it to see how your glucose control is?
Yeah.
Okay. And have you, are you doing it every 3 months, or how often are you seeing the doctor for it?
When I need it, doctor.
I see.
with
Okay.
my GP.
Okay. Yeah. So, and apart from the diabetes, do you have any other chronic condition?
Not that I'm aware of, doctor.
I see. Okay. And I'm just checking, have your blood pressure and blood pressure has been okay in the past?
Yeah.
I see. Okay, that's good. And I just want to also know, do you smoke?
Yes, doctor, I do.
Okay. And how many cigarettes per day?
Maybe 6 or 7 cigarettes per day.
Okay. And how about alcohol?
Occasionally, doctor, in the weekend.
Occasionally. And how many drinks can you have over the weekend?
Maybe two glass of wine.
Okay, okay. And apart from the medicine that you are taking for your diabetes and the insulin that you take, are you taking any other medicines?
No, doctor.
No other medicines. And have you had any other surgeries in the past or any other hospital admissions?
No.
Okay, okay, I see. And have you, in your family history, your parents, they had diabetes or heart disease or blood pressure?
My mom had diabetes.
Okay, okay. And other than this, overall, do you have any other health concerns?
No.
Okay, okay. And just want to check, are you taking, do you do regular exercise?
Mm, Occasionally, doctor.
Okay. And through your diet, are you trying to control your sugar levels as well?
Yeah.
I see. Okay. So, so Mr. Smith, after all the history, I just wanted to let you know that when over the couple of years since you're saying you have diabetes for the past 20 years, and you have been trying to manage it with the medicines, insulin, and you have been taking care. However, still, if you have diabetes over the years, it does affect lot of areas in your body. And one of that is your eyes. So eyes are very prone to, because of high sugar levels, there are some changes that happen in the eye. And it can lead to multiple symptoms, like you can get double vision, or sometimes you can just have a blurry vision, double vision, and um, the eyesight can and there can be other conditions as well, which can be which happen because of high sugar levels. So I would be giving you a referral and to see the eye specialist and get your so the eye specialist would thoroughly check your eyes, looking behind the eyes to check your the behind of eyes that we have the retina where the images form. He is going to check that, and he would also check your eye pressure in the just to see that it's okay, because sometimes that also gets affected. And the lens also, we need to check that there is no cataract happening over there. And um, so I will be giving you that, and I will also be checking your blood sugar level today, how it is, and would do your some baseline blood tests as well, and your urine test as well today, just to see what that everything is okay. And I would give you some reading material to read more about the changes in the eyes that happened because of diabetes. And even the nerves, they do get affected if you have high sugar levels for a long time. So I would give you some more reading material to understand more about what effects the high sugar levels can have overall on different organs. And we will do your blood test as well. So after that, once you make your appointment with the eye doctor, we would get a more clear picture of what is happening. Are you with me so far, Mr. Smith?
Anything else that I need to know, doctor?
For now, I know, I think that should be okay. If I'll just give you the reading materials and then probably make another appointment with you, and we can just review the results together and also get the feedback from the eye specialist.
Okay. Dr. Mariam, you still get 1 minute. Nice approach, nice performance. Few things is here. When you took a history, what I noticed, you only like focused on diabetes. You didn't ask me any other reason for diplopia history. You didn't ask me headache, either any eye pain, any weakness, like any stroke symptoms, any space occupying lesion symptoms. Like you just focused on diabetes. But you need to ask other differential, because your task was suggest potential causes for his symptoms. So in this case, you need to mention other differential diagnosis as well. Okay, so those things are missing. Your task is not management here. If time permits, you can mention about like you are going to do some investigation, you can make a referral. That's okay, but to be honest, in here, your task is not management. So just focus on your task. So take a details history. You can give like lots of differential. You just mentioned diabetes related eye changes. Try to be more specific. What do you mean by that? And what could be your other differential? Okay, so here task was not complete. So let's discuss the case. Mr. Smith, 67 years old, diabetic, visit your clinic complaining of double vision, particularly noticeable when he looks to the right. Aside from his diabetes, he has no other significant medical issues. Your role is to gather a thorough medical history and suggest potential causes for his symptoms. So ask about onset and duration for double vision. Ask about like diplopia, when that started, how long it has been present, either it is sudden onset or gradual onset, frequency, severity, and any factor worsening, relieving factor, associated symptoms. Very important. You should ask about any eye pain, any headache, vision, blurring of vision, any weakness, numbness also are in the bodies. Eye movement. So here diplopia worsening with any specific eye movements, such as looking in a certain direction or focusing on object. Medical history. So Mr. Smith, he got medical condition of diabetes for a long time. You should ask about any other chronic condition like any high blood pressure, eye problem, eye surgery before, cardiovascular risk factor, neurological condition. Okay, any medication he's on, lifestyle and occupation, and you can ask about social history. So here, differential diagnosis is a diabetic ophthalmoplegia, because it's a cranial nerve palsy, like third nerve palsy, leading to weakness or paralysis of the eye movement muscle. You need to consider for that. And diplopia, especially when looking to the affected side, is a common symptoms for that like cranial nerve palsy. Another reason it could be due to ischemic optic neuropathy. Diabetic can increase the risk of vascular complication, so that ischemic optic neuropathy can happen. Diabetic retinopathy is a common complication of diabetes, can lead to vision problem. Other orbital mass or lesion. Other thing it can happen like due to myasthenia gravis, which is an autoimmune condition, can cause weakness of the eye muscle resulting in diplopia. Okay, thyroid problem. So definitely you should ask about thyroid problem, any brain stem stroke or tumor, or other potential causes of diplopia. For that you need to do thorough physical examination, neurological assessment, appropriate diagnostic test to confirm the diagnosis. Okay, so those are your potential causes for his diplopia. Any questions for this case? Can we see the PFE before talking to the patient? No. So if your task is, for example, there are different tasks. So sometimes STEM, like history and physical examination, will be given on the STEM, and your task is like based on the history, physical examination finding, you need to make a diagnosis and explain or counsel management plan. So that time you might get PFE card on the STEM. Okay, that means it will be written like either any positive findings on physical examination. Okay, but usually history taking case, you will not get PFE before your 8 minutes started. So within that 2 minutes it's reading time, you'll get only STEM. Last case, anyone wants to perform? Do you guys have any particular question for random role play session? I'm happy to answer. In this year, your clinical examination all mostly on online base. So online exam, you will get 2 minutes reading time and 8 minutes performance time. For that 2 minute, when that 2 minute starts, that means STEM will appear on your screen, and you are not allowed to write anything within this 2 minutes time. So my advice will be just read the case very carefully, think about all other differential, and based on the case, think about key point. Okay, and when your 8 minute starts, you can write. You are allowed to write within this 8 minute time. So my suggestion would be like when your 8 minute starts, you can quickly write differential key point on your paper, so that when you are going to wrap up of this case, just quickly have a look on your paper and just check either have you missed anything or not. Okay, and always when you are going to explain anything to your patient, just checking understanding. Okay, so in between you can ask like, are you with me, do you have any question, or feel free to ask if you have any question. Just check patient understanding. For a beginner, how we can start our preparation for role play? To be honest, just honest opinion, your first month it would be hard, because when I'm going to do like random cases, few things will be going above your head, but definitely you will overcome it within like 1 month. Like that's why I advise you guys like to join like theory course when you have that cluster wise approach, when you understand about the structure, because there are like lots of mnemonic you can come across with these theory courses. then it will be much more easier for you. Like within 1 to 2 months, you will understand how to take proper history, your structure, and then it will be like helpful for that random role play. But you know that like in your main exam, that random role play, like random cases you will get, okay? So just stepwise your approach or preparation would be fast, go through that theory classes, cluster-wise approach, and then start random role play. For the beginner, my advice would be just start reading your handbook, start your theory class, and then every day 1 or 2 case you can perform with your study partner, and in the meantime, like within 1 month, when you understand, then you can start like performing random role play. So for the random role play session, you need to contact with Dr. Arshad, and also theory course, both for random class and theory course, you need to contact with Dr. Arshad. If they mention like history for 4 minutes, and PFE will appear after that, so it will appear automatically after 4 minutes. You don't need to ask. Okay. And my suggestion for you guys, just go through your handbook. Handbook, even though it's a very old, but still it can give you idea about what does it mean, key point, what does it mean like critical error. It can give you idea. And there are like many important cases, they're coming frequently from that handbook. You can change the management as per recent guideline, but still handbook, I would advise like go through handbook case, and also try to find a study partner, at least 1 to 2 study partner. Okay. And start preparing with them, with performing like role play. In this clinical exam, there is no point just reading by yourself. You need to perform. To be honest, like there are many good candidates I have seen. Definitely they are very knowledgeable, but because of lacking of that role play in the main exam, they didn't perform up to that level. Okay. For physical examination on online system, you need to mention about what point you are going to check and anatomical landmark, because most of the physical examination you need to explain to the medical student. So medical student might ask you, for example, if you mention you are going to check carotid pulse, so medical student might ask you, doctor, where you need to check carotid pulse. So you need to specifically mention about the anatomical landmark, like that. Okay. Dr. Repa Ben, I don't understand. What do you mean? Like now I'll turn the hand, and does it need to be in elemental language? Look, if you are going to explain a step of physical examination to a non-medical person, you need to explain about medical term in a layman term. Okay. If you are using any medical jargon, your patient might ask you. But for the medical student or nurse, you can use medical term. Lichen sclerosis, why referring the case to the specialist for biopsy is considered as a critical. So if your task is management, so management, always remember it comes under like three steps: investigation, immediate, and long-term management. So investigation, biopsy is a part of your investigation or management, and biopsy can be done by GP, or if GP not competent enough, they can refer this patient to the specialist for taking biopsy. Both things are correct, but as long as you are mentioning about biopsy, still okay. And for the treatment, like in sclerosis, like you need to refer this patient to the specialist for the further treatment. In face-to-face exam, so that physical examination definitely is a different thing for face-to-face. You need to perform, okay? For example, like, yeah, thyroid nodule exam case. If it's coming for face-to-face exam, and if your task is perform relevant examination, so in that case, you need to perform thyroid examination, like thyroid physical examination. But if it's a history taking case, that means you need to take a history and you will get the physical examination finding from the examiner. That time you need to just ask the findings. You don't need to perform. So those are two different things. One is the like a history and physical examination finding from the examiner, and another is just physical examination performance. Any question? So that's how our so I prefer to do random role play in this way. And when I'm taking class every week, and I'm taking class I'm discussing case monthly basis. What does it mean? So for example, like now I'm discussing July cases. So the case frequently coming, the case which are like difficult, those cases I'm discussing in that random role play session. Okay, just a sample case. It's very hard to say. In this year, I think only online exam. I'm not sure for next year. For me, actually, I was the candidate, like I took my whole preparation for face-to-face exam, and I ended up with giving online exam. And thank God I passed in my first attempt. So look, both, I would say both have their own like pros and cons. As long as you are having good grip for recent cases, you have good time management, knowing the case very well. I think for any like a form of exam, either face-to-face or online, you will go through it, okay? Anyone wants to perform any more case? Any feedback for today's role play session? So today I discussed most of the case that coming recent month. Definitely, it's very hard. It's very hard to go through all the handbook cases, but there are like very important cases coming. For example, like there is UTI in a male, uretary colic, encoparesis, mechanical low back pain, also wrist card, like few physical examination, some ONG cases, for example, like smaller than gestational age, like few cases are really important in handbook. So I would suggest like go through that handbook cases. Not all, but there are like quite few important cases. Um, okay, so I'm going to finish today and see you on my next class on next week. Thank you, everyone. Good night.